Good morning, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today we have a very, very important episode with a very important guest. Today I'm going to be speaking to my previous Chief of Pediatric Emergency Medicine at the Children's Hospital of Pittsburgh, past, present, and hopefully future mentor, Dr. Rick Saladino. Dr. Saladino did his pediatric residency many years ago at the Cincinnati Children's Hospital, then pursued a pediatric emergency medicine fellowship at Boston Children's. Rick remained as faculty at Boston Children's for several years, where he did some clinical and some research work. For me, perhaps the most important and impressive aspect of Rick's work during that time was his contribution to the development of the conjugate pneumococcal vaccine. If you listen to my show and if you know anything about pediatric emergency medicine and pediatric in general, you probably know that pneumococcal vaccine has made childhood meningitis, bacteremia, pneumonia, and even acute otitis media a disease of the past, almost. And this is why I always teach the residents, for the most part, less is more. Rick's work in the animal lab provided the preliminary data demonstrating the protective capacity of anti-pneumococcal antibodies to prevent pneumonia, bacteremia, meningitis, and even death. Rick was then recruited to Pittsburgh, where I met him, and he was the division chief of pediatric emergency medicine, a role that he held for more than 18 years. He recently retired from that role and currently serves as the senior associate vice chair of faculty affairs in the Department of Pediatrics at the University of Pittsburgh School of Medicine. And not surprisingly, he also has remained as a faculty member in the emergency medicine department. As Rick told me once, I just cannot not see patients. That's a double negative. Rick is also, very importantly, the person who introduced me to many of those rules that I speak about. We used to learn about them in fellowship from him all the time. So, really, he is the inspiration behind the podcast and what I teach to residents and medical students every day. Welcome, Rick. How are you feeling?
Very well, thank you. Good morning,
You're
Yaron.
welcome. You're
Thank you
welcome.
for that very nice introduction.
You're very welcome. Thank you for being on the show. I've been wanting to have you on the show for a while, and you're busy, I'm busy. It took a while. I'm glad we made it happen. And what I really wanted to talk to you, Rick, which is kind of interesting, I distinctively remember learning a number, 10 or so, of the rules specifically from you. And I can even recall the event on when you told me them. I would love to hear from you, Rick, which of those rules that you've taught me is your favorite, the rule that you consider maybe the most important, when did it originate, what it means to you, really anything you want to tell us. So which one would you say that is?
Well, I think that's easy for me to answer because it's a rule that really can be applied in so many circumstances. And it's my rule. It's not the patient's job to prove that they are sick. It's your job to prove that they're not. I don't really recall when this rule became embedded in my clinical consciousness, probably fairly early on. Certainly, it's something that we all teach in some way or another. That said, I'm very intentional in messaging the importance of the rule. Say, for example, a resident reports that the heart rate of her 15-month-old patient is 160 and tells me, but she's febrile of 38.7, as if that fully explains the tachycardia. Now, my reply is usually something like, you're probably right. But remember that the most sensitive indicator of intravascular volume in the young child is the heart rate. So let's not make that heart rate of 160 okay for this patient by simply attributing it to the fever. We might be missing early signs of shock. And then, Yaron, I deliver the punchline. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. So how about some corroborative evidence? What's the mental status of your patient? What's the capillary refill time, and so on? And then I move on to let's recheck the heart rate after the fever comes down with some acetaminophen. If the heart rate drops with resolution of the fever, then indeed the fever drove the pulse. But if the heart rate remains high, we worry about shock. So this is as much a clinical rule as it is a lesson or prompt for being compulsive and attentive to the clues that your patient provides you.
That's great. I love that. I love that. And I got to tell you, so I think about that rule all the time. I teach it to my residents all the time. It's not the patient's job to prove that they're sick, it's your job to prove that they're not. I think the way that that rule comes to my clinical life almost weekly is with newborns with fever that I see. The hospital where I work at, the nurses are so good. Many times they go into that room, they swab the child right away with one of our PCR swabs that checks for like 100 benign viruses. And before the workup is completed, the resident comes to me and he says, Dr. Ivan, the respiratory virus came back. The kid has rhinovirus. I think we know why he has the fever. I think we're good to go. We're done. And I remind them, it's not the patient's job to prove that they're sick, it's your job to prove that they're not. A respiratory viral panel really did not prove the child is not sick. It just proves that he has a benign virus of some sorts and he's going to be fine. I still, in my opinion, have to prove that he's not sick, meaning does not have meningitis, does not have pneumonia, does not have bacteremia, etc. That's how I demonstrate that rule. That's how it translates to my almost daily life. But I think that's a great example. Let's not attribute to tachycardia to the fever. Maybe there's something else. I love that.
Well, you're a great teacher. I know you are, and I've seen you in action. I think that part of being able to speak that rule out loud gives you an opportunity to teach in a diplomatic way, like, "Hey, hold on, we're not going to discharge this patient in the next 3 minutes. Let's reconsider." You don't say that out loud. You give them the rule with a smile on your face. It's nice diplomacy. It's a way to introduce the teaching that you're about to embark.
Thank you. Thank you very much. What other rules come to mind that you can think about and tell us more about?
Well, I will launch off of your last comment about taking a pause and looking at the patient who has a rhinovirus in their nose. Another favorite rule of mine is simply go to the bedside. As we know, among many other processes in medicine, documenting in the EMR has taken us away from the bedside. And my mission as a clinician and as an educator is to get back to the bedside. Any opportunity I see at the bedside to learn from the patient is of great value. A simple example is writing an order for a bolus for a dehydrated patient. So you have a 3-year-old with intermittent fever for 4 days, a few episodes of vomiting, and a bunch of loose stools, who on exam is tachycardic with delayed capillary refill time. Well, common things occur commonly, right? This is viral gastroenteritis with fever and dehydration.
Sure.
Well, maybe not. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. So now I say, let's go to the bedside. Evaluate the patient's response to your first bolus. You expect the heart rate to decrease and the capillary refill time to improve. But instead, you notice that the heart rate has increased by a few points. You listen carefully. You may hear a few crackles, maybe even a gallop. So now at the bedside, well before the patient crumps during your second bolus, you suspect failure. And now you start thinking, maybe the etiology is not fever gastroenteritis, but MISC with myocarditis. Your observations of subtleties on the exam were available to you only at the bedside. Hearing from your nurse at the time of hourly vital signs check that your patient is persistently tachycardic and now tachypnic is too late. So do yourself a favor and your patient a favor, go to the bedside.
Yeah, I love that. I think that's great. I agree with you 100%, and I blame myself by doing the same. The EMR has made us very much in touch with our computers and our screens. Probably not nearly as much time as you used to use with with the patients. I certainly see the value of that. I'm to blame as well. I spend a lot of time in front of the computer trying to manage the patient in front of the computer, which is probably not a great idea. So I love that. That's great.
Well, we talk a lot about discerning in the pediatric patient the sick from not sick. It's one of the basic teachings for whoever comes to us rotating through pediatrics or pediatric emergency medicine.
Sure.
And I think discerning who's sick and who's not, or this gestalt of what your patient looks like, is so important to us. We know that as pediatricians. You can't do that from a distance, particularly the distance from your computer to the room. So getting to the bedside is such a rich experience in things that your patient is trying to tell you. I love literally standing at the bedside. And I think you teach this as well, turning away from the monitor and instead putting my finger on the radial pulse, watching the respiratory rate and the effort of respirations, or looking at a belly, looking at the perfusion, looking in the palmar creases. Are they pale? Well, boy, that might be the first indication of anemia. So there's so many things you can learn at the bedside. So I really love preaching that as well.
Yeah, and I think I remember doing a sedation with you in fellowship, and you kept telling me, because I kept looking at the monitor, monitor the patient, not the monitor. So that's probably related as well. I love that.
I'm sure I said it with
Uh,
diplomacy I was very pleasant in my delivery,
of
was I
course you
not?
were. Of course you were. Absolutely. What else can you tell us about any other rules that are particular liking to you and stuff that you can maybe elaborate more about other rules that you use?
Well, I don't want to sound like a broken record, but I do have a lot of favorite rules.
You
And
know,
another one of
you are
my
in good,
favorite,
you're not the only one. I probably say to
well,
the residents all the time when I mention some rule and I say, this is my favorite, and they say something like, wait, I thought rule number 37 was your favorite.
that's right. This rule, I think, originated on the procedural side of things more than the physical examination side. And anyone who's been in the same place at the same time with me in the medical context knows that I love procedures. So this rule that is pretty commonly quoted by me and now many others is do it the right way, the same way every time. Now that needs a little bit of explanation because it sounds pretty rigid, but it's not really. I developed this rule during my days in the animal research lab in Boston. One of the procedures we performed as part of our experiments looking at gram-negative shock was venous access by femoral cut down technique.
Oh,
I learned during the course of performing probably more than 1,000 cut downs that procedures are not always straightforward, that the anatomy occasionally varies from what you see in the textbook. So, in order to deal with the tough procedures and unusual anatomy, I taught anyone who came into my lab to first learn the anatomy, then learn the technique, and then practice the technique and the procedure the same way every time. It's just repetitions. It's like a sport. Repetitions make you better. So, doing it the right way means knowing the anatomy, the equipment, the prep, every step of the technique. Doing it the same way is like coaching young athletes that it's not practice that makes perfect, it's perfect practice that makes perfect. I know that's a cliche, but it really is true when you try to become an expert at the technique to the extent that when the procedure's not going well or the anatomy is anomalous in some way, you can change your approach slightly while still relying on all the exacting steps that you have practiced and that are part of your muscle memory. By doing things the right way and the same way every time, you optimize your chance of success and minimize the chance of failure. So I chant this whenever I'm teaching a procedure, and then ultimately when we're doing procedures.
yeah, so this is something that I definitely remember telling me in fellowship many times. Do it the right way, the same way every time. And again, I teach that to my residents all the time. I think this one specifically comes to mind when I work with the residents and we do an LP on a newborn with a fever. I think a lot of our residents are a little intimidated by the procedure, especially the emergency medicine residents, because the baby's so small. And I always tell them just do it the right way, the same way every time. If you got something that works for you, be a little obsessive about it. Do it the same way every time, and it always works. Yeah, but this rule comes up with procedures all the time, and I love teaching them. Stick with what works. If it's not broken, don't try to fix it. I love that.
Right.
What about? I know you had some more rules with regards to managing some patients with some specific conditions like shock. What about that?
Yeah, well, whenever I talk about shock, I'm reminded of my chief resident in Cincinnati who would come up to the floors and pull us down to the ER saying, I can smell shock. Let's go.
That's
And
hilarious.
I've always liked taking care of sick patients, as we all do. I think we love emergency medicine because there's the breadth of medicine, but taking care of a sick patient is really gratifying, as you know. And when I take care of a patient with shock, I always feel like I'm being tested. Like I got to get this right because kids are very resilient, but there is a precipice out there, and I don't want to go over the precipice with this patient. So my rule for this is the management of shock is a chess match against death. No, that's a little dramatic, I realize,
That was a little
but
dramatic.
it's the chess match that I want to focus on. I think we all sense this rule intuitively, particularly when a resuscitation is in its chaotic phases, right? We're trying to think of everything and just get our act together. But I quote this rule to put some urgency into how we care for patients with shock, particularly as an educator. So it's all about the pediatric patient who is sometimes a bit shifty, meaning we're not always able to see clearly just how sick they might be, or more importantly, how sick they might get. Our sickest patients do require the perspective that we're in a chess match against death, right? We want to stop way short of that. So, what do the best chess players do? They imagine the future, one move, two moves, three moves ahead. And so that's what we do when caring for kids with shock. We see a child with fever, tachycardia, delayed capillary refill time, and we administer a first bolus. And of course, we go to the bedside to see the response to those fluids. And in the meantime, we anticipate that if the heart rate and perfusion don't respond, we'll give a second bolus. But we're not going to sit down at that point because we might be giving a third bolus. But boy, now we're getting into some territory where we need to be at the bedside. And we start thinking, why might the patient be in shock? Well, there's a possibility that this is septic shock. So that prompts me to order the antibiotics early on. Thinking a few more moves ahead, I also wonder, if I need to give a third bolus, maybe I should write the order for epinephrine so that I can start that drip when I need it without any delay. And maybe I should think about what the dose is for hydrocortisone if I think forward about fluid resistant shock. What's my response to that? Will I ultimately need to intubate this patient if things really start circling the drain? But right now, the patient may not have much in the way of respiratory distress, but I'm thinking forward, what happens if? So I continue this chess match and I roll out the airway cart. And if my worry increases even more, I ask the nurses to drop the intubation meds. I've never been sorry to have over prepared.
I love that. I think that's totally true. And I guess maybe in my subconscious, when I heard that rule from you in fellowship, I came up with my own rules. So in one of my episodes that I recorded in the past, I speak about rule number 39, which says a good ER doctor is always ready, be a step ahead. And to me, that plays a role in shock or when I resuscitate a child, mostly a child, those babies that come early in the morning in what we think is SIDS. I ordered the epi and I always tell the nurse, let's get another dose of epi ready to go, but not given yet. So, and I teach the residents again, a good ER doctor is always ready, be a step ahead. So that's how I think about that rule, but must have subconsciously learned it from you because I remember you saying that.
Well, you always did a great job of thinking ahead, and even for a common presentation of asthma, there's a whole spectrum, and we see severe asthmatics, so we got to be ready for that kid as well.
Sure.
And we sort of approach the asthmatic as routine. Okay, let's start albuterol, whether we're giving puffs or nebulized albuterol. Maybe we start a line, give some steroids, whatever we're doing in that regard. But that doesn't take much time to think about because the child comes in wheezing. How much time have we spent really watching that patient and trying to determine just how severe their respiratory distress is? So I always think, okay, I'm going to start my standard meds, but I'm going to have a dose of epi around if this kid's severe in their respiratory effort at all. And then once I give one dose, I drop two more because I figure, well, if I gave one dose, I probably underestimated the severity of their illness and I got to be ready.
Yeah.
Thinking ahead is, I think, such a great strategy. And nobody worries about wasting a dose of epinephrine into the sharps container
Sure.
if you don't use it.
Yeah, absolutely. I couldn't agree more. Awesome. Yeah, so those are good rules that I one can use in life, being a step ahead, being always prepared, etc. I love those. And again, I teach them I find myself teach them to my kids every once in a while. A good ER doctor is always ready, a good student is always ready, be a step ahead. I think that's great.
Yaron, I have a couple rules that I put on my list for us to talk about that are rules sort of in the keeping me humble category.
Yeah, let's hear
And
them.
one of them is if you don't recognize the anatomy, it's time to call for a consult. And I do a lot of procedures, and I think that all those repetitions have made me pretty good at a lot of procedures. But one thing I always keep in mind is that parent expects me to be perfect. And if I can't be perfect, I need to back off. So again, this sort of rule speaks to doing things the right way, the same way every time. And earlier I alluded to the importance of knowing the anatomy, learning and practicing technique. Well, if you don't recognize the anatomy as what you've learned, then you ask for help. What appears to be a simple lip laceration may in fact involve the muscle layer. So if you can identify that the muscle's intact, great. If you identify the muscles lacerated, you're not quite sure how to put that back together, well, the cosmetic defect may be significant and you want better for that patient. Similarly, kids lead with their heads, so they're always cutting their face, but they also lead with their hands. So that simple laceration over the dorsal aspect of the MCP joint may in fact involve the tendon. So you ask yourself, can you visualize the entirety of the wound and ensure that the laceration does not involve the tendon? Well, if you're not absolutely sure, then ask for help. As I said, I love procedures, and I feel like the domain of the pediatric emergency medicine physician includes every procedure in the textbooks of pediatric emergency medicine and pediatric emergency procedures. But if I am uncertain, it is incumbent upon me to defer to a consultant, whether that is a PEM colleague or a subspecialist. So I try to stay humble in that regard as well.
Yeah, I think that's probably a good idea to do. Something we should all keep in back of our minds. I look at pediatric emergency physicians as sort of jack of all trades. I can certainly do a lot of procedures, and I see a lot of patients. I see a lot of pathologies, but I'm not a specific expert in one field. There is always somebody who can help. And I remember you teaching me that again and again. If you don't recognize the anatomy, it's time to call for a consult. I think it's very important to know what we don't know.
Your own.
Yeah.
Speaking of knowing what we don't know, one of the things that Gary Fleischer taught me a long time ago, and in fact, it was on my very first shift when I went to Boston. He told me something that I've remembered a long time. So we talked about the subtleties of caring for the pediatric patient, including thinking hard about the clues we get from history and examination, being an exacting technician, always staying ahead of the sick patient, all those things. How do we ingrain all those traits of compulsivity and vigilance in a way that helps us be a great clinician? Every time I work a shift in the ED, I think to myself that my next patient is going to teach me something I didn't know, or that patient is going to reinforce something I already know. Seeing a lot of patients builds a sort of pattern recognition, whether that is a sequence of data we obtained during acquisition of the history or what we learned via a careful, compulsive examination. It's easy when we think about making the diagnosis of, say, poison ivy. The chief complaint's a rash. The history includes a child was playing in the woods 2 days ago. And on exam, you see patches and streaks of red, raised bumps and blisters. That's pattern recognition. Even without the history, the appearance of the rash is classic enough to evoke pattern recognition. And if there's anybody in your crowd, Sharon, who listens to your podcast, maybe they'll remember dewdrops on a rose petal, classic for varicella. Again, just simple pattern recognition. Now, on the other hand, the patient with myocarditis may not demonstrate such an obvious pattern, and that's when medicine is difficult. However, the more patients you see with myocarditis, the more experience and information you have in your data bank to pick up on the signals amidst all the noise. Repetition and careful observation allow you to catch that one child out of 150 who presents with classic signs and symptoms of bronchiolitis, who instead is tachypnic and poorly perfused due to myocarditis with heart failure. That's my goal, is to find that one kid out of 100 or 200. So back to Gary Fleischer, my first shift in the ED in Boston. Gary told me the way to become an expert in your field is to see a lot of patients. And Yaron, I really took his words to heart. I've always wanted to see another patient and another patient. Gary is an incredible clinician, astute beyond description. Watching Gary in the ED was inspirational. And if he said I would become an expert in my field only by seeing a lot of patients, well, that's what I was going to do. And Yaron, I am still working at it.
And I think that's a great rule. I teach that rule to my residents and my medical students all the time. The way to become an expert in your field is to see a lot of patients, and a lot of times they don't really understand what I mean, and I demonstrate it to them. I think I found a way to demonstrate to them very easily, and it kind of shocks them. every time. So this is now rule number 47 from episode 11 that I recorded. The way to become an expert in your field is to see a lot of patients. And I tell them, when they don't really understand what I mean, I say something to the extent that you just came out of room 4 and you presented this patient and you told me he has a URI. And I agree with you. How did you know that? So the resident would say something, well, Dr. Ivan, I've seen URI, 17 times, so I know what it looks like. And I say, that's great. So now you have to see mild asthma 17 times to recognize mild asthma, moderate asthma 17 times to recognize moderate asthma, and severe asthma 17 times to recognize severe asthma. That's a lot of patients. So, really, the way to become an expert in your field is to see a lot of patients, a lot of mild, a lot of moderate, a lot of severe. There's not a lot of severe out there, so you really have to see a lot of patients. And when I say that, I feel like they really understand what that rule means and they take it to heart.
Yaron, I really love that explanation. It really amplifies the magnitude of patient experience that we need to become experts in our field. There's the rule of 10,000. You need 10,000 repetitions to become expert or to master something, whether it's a business technique, medical procedure. 10,000 is a lot.
That's a lot.
10,000 steps is a lot to achieve in a day, as we know from trying to keep our health up. Nonetheless, repetition is a good thing. I think people get it when you explain it the way you do. And you can explain, I sometimes, if I know someone has interest in music or athletics, you can compare it to how you practice to become perfect in delivering that sonata, or to deliver a pitch, or to achieve near perfection in how they swim the butterfly, those sorts of things. It's all about repetitions.
Very nice. No, I couldn't agree more. So I guess there are some more rules that I know you wanted to discuss, maybe not so much from the clinical world or maybe the professionalism world. What else did you have in mind?
Well, a couple that might be in the professionalism domain, only because I use these rules not infrequently. It's another double negative. These sorts of things come up, and it's nice to teach your own students, residents, PAs, these sorts of rules, because it makes them so much better at what they do, and it makes them aware of how they are perceived by others. And the first of those is meant to be a little bit of a wisecrack, but the rule is don't be late, and definitely not with a cup of coffee.
I love that.
So again, it's clearly a reference to professionalism. In particular, not being late to a shift or a meeting or a presentation is simply being respectful of your colleagues. Think of the message you're putting out there when you arrive late to your shift and you're carrying a cup of coffee. Not only were you not too concerned that you were going to be late, but you're also thinking of yourself when you took even more time to buy your cup of coffee. So I say, yikes, don't be late. Better yet, be early.
Yeah, I could not agree with you more, Rick. And I think that's a combination, a little obsession of mine, I admit, probably a combination of having worked with you or people like you in my career and having served in the military, where being late was just a bad idea. It was never an option. And I actually recorded a whole episode with 3 rules. I'd love for you to hear them and tell me what you think, specifically about being late. I don't even remember where I read them. Certainly the one about not being late with a cup of coffee from you, but I've also heard early is on time is late, and late is unacceptable. I teach that to the residents all the time. And rule number 41, if you're not 5 minutes early, you're late. I think that's very true. And rule number 42 is the one I heard from you. Don't ever be late. Definitely not late with a cup of coffee for the obvious reasons. So yeah, I
Well,
think that really drives me a little bonkers when people are late for their shift. Specifically, I think in emergency medicine, being late really has to do with affecting your colleague. So if I'm late, then my colleague is going to be late to leave. I don't want to relieve my colleague late. We are all busy. Many of us are exhausted at the end of the shift, and if me being late means he has to stay later, I think that's unfair. That's not something we should do to our colleagues.
that really speaks to the other rule I like to talk about, and this is very positive, and it's just simply manage up. So yes, it's professionalism, but I think it's a way of getting people to work as a team more effectively. So, as providers, as ED docs, we don't operate alone, right? We're part of an orchestra. And many times, as the ED doc, we're the conductor of that orchestra. But part of leadership is giving space to others so that they perform at their best. Managing up refers to building up those around you. Doing this serves many purposes. Would you agree? So we might say, it was nice to meet you when you talk to the family of your patient before leaving the exam room. I believe you already met my resident doctor, Dr. Smith. She is outstanding. And I think you met our nurse, Stacy. She's incredible. So those are just, yeah, they sound like nice things, but they're really implanting in the heads of our patients and anyone who's within earshot that we're working as a team. Just before shift change, you might say to the family, Dr. Gonzalez will be taking over for me. He is excellent. So you've built up your team, you've guided some of the expectations the family may have, and maybe even modified some of their perceptions in a positive way. And in the ED, we do need to create perceptions that are positive because there's so much anxiety in the emergency department setting, and that sometimes creates negative perceptions. But
Absolutely.
also, let's think about extended members of our team. How about managing up your consultants? So you check on your patient awaiting casting and say to the family, the orthopedic doc is really busy tonight, but we'll be in to see you as soon as she's finished putting on that cast down the hall. She is just fantastic. Or you say, well, you're standing with the family in the trauma bay and you say, the doc you see at the bedside now is our trauma doc. Our trauma team is phenomenal. We are going to take really good care of your son or your daughter. So again, you've managed some expectations. And now this, I think, is important. When the individual you have described in this sort of way is within earshot, now you've set expectations for that person in a very diplomatic way. So they know that you see them, you know who they are, and you have high expectations. I think it's a team building kind of approach when you say manage up.
Yeah, I couldn't agree more. Again, this is something I remember learning from you. I've since then modified it to rule number 54: set up your consultants for success. I diagnose appendicitis probably once a week in our hospital, and I always say something to the parents something to the extent of, "Mom and Dad, little Johnny has appendicitis, but don't worry, our surgeon will be with you soon." They do this every day. They are excellent. Your son is in wonderful hands. He'll be great.
Yeah, I love that. I know you do that very well. Again, I think it's a great team building exercise. It makes everybody look good. You avoid some of the negative flow that we sometimes fight against in the emergency department. So Yaron, we're making it sound easy, like we do this all the time and everybody's one big happy family. And maybe it's not. Sometimes there's conflict. And I have another rule that I want to bring in to sort of deal with that. It's a rule that I've tried to live by my entire life. I will guarantee you that I've not always been successful, but I try really hard. It's an influence from my own mother. And I call it the tiebreaker rule. And this is when everyone around you is arguing about things other than those that serve the best interest of the patient. And that's when it's time to call someone's mother, or at least imagine what she would say. So, to give credit where credit is due, this rule is a version of a story within a commencement address that I read that was written for a graduating medical school class. And by the way, the author happened to be an emergency medicine doc, which I was really pleased with. The story was one that we see happen in the ED all too often. Two consultant services, each arguing that the other service should admit the patient. How often do we see that? Now, these arguments are, as you know, driven by emotion, stubbornness, fatigue, and who knows what else. But what is often lost during all of that arguing is what's in the best interest of the patient. So in the story, the ED attending simply asked the consultant to call his mom, explaining that his mother, or whoever serves as his North Star, will know on which service the patient belongs. And of course, the resident never makes that call. He knows how to do the right thing. It's really that simple, doing the right thing. And I don't think any of us, when we graduated medical school, imagined that someday we would be arguing to block an admission or whatever. But these things happen. It also happens that deep down, we all know how to do the right thing irrespective of the circumstances. So when I'm faced with two parties at odds, I make a suggestion that serves the best interest of the patient, at least as best I can see it. So in other words, I'm asking them just to do the right thing. Now, if I get more pushback, I suggest the tiebreaker. Well, call your mom. And I can tell you it always works.
I love that. That's, I don't remember learning that from you. I'm totally going to use it from now on. Yeah, because I think we often get into some maybe personal conflicts that certainly don't serve the patient at all. But if we are reminded why we're here, why we're doing what we're doing, and this is a great way to be reminded, we kind of maybe wake up and understand and realize, we're really here for the patient. Doing an admission is 10-minute thing. Let's just get it done and take care of the kid. So I love that.
I agree. I agree.
Yeah. Rick, those are really some excellent, excellent examples. I really love hearing them. And it's really amazing how those rules can come to play in so many ways. I love hearing those examples. I can't thank you enough for coming on the show. I think, oftentimes when I think about my life, I think about some situations I've been at and how privileged I was to get accepted to medical school, going through the training I did. And I think probably one of the biggest privileges I had was somehow, I don't even know how, matched you to fellowship at the Children's Hospital of Pittsburgh and working with you and the rest of the team there. It was an amazing, amazing experience. Those of you who are still in training, pediatric or emergency medicine, I highly recommend fellowship in pediatric or emergency medicine. How obviously I'm biased. And if you can live by those rules, we recommend them as well. Thank you, Rick, very much for coming on the show. I hope
Well,
we can.
absolutely, absolutely my pleasure. I'm very proud of you, Huron.
Thank you.
You've developed so many great rules yourself. And, we call them rules, but they're not as rigid as a rule. They really are, suggestions for how to do the right thing, which is maybe that overarching goal that our moms teach us along the way. But very, very happy to join you today and really love the conversation. Good
Thank
for you and good luck, continued success.
Thank you very much, Rick. Hopefully, we can do this again, find a different topic.
Great.
Awesome. Thanks again, Rick. Have a great day.
You too.
Bye bye. That is it for today, guys. Thank you very much for listening for another episode of PEM Rules. Please check out pemrules.com, submit any feedback, contact me with any questions or requests you have. Would love to hear from you. Have a great day, everybody. Be safe out there.